this is basically the list of what is available, sort of mainstream available. Active surveillance basically means don't do anything currently, monitor you closely, repeat the PSA, possibly repeat the biopsy, and if something changes and either the physician or the patient gets scared, we act upon it. There is radical prostatectomy surgery to remove the prostate. You can go about that sort of the traditional way, open or by the robotic way. Radiation therapy involves either external radiation or implanting of seeds. You can perform cryotherapy, which is freezing the prostate. There's hormonal therapy or chemotherapy, and that's usually used when the prostate cancer has spread outside the prostate. And then proton beam therapy, again a newer modality, and then at the bottom, HIFU, which is why we're here tonight.
These slides are also covered on your disc, is that?
No, they're not. The disc itself is from International HIFU. That is, most of that is, I'm going to show you a little clip of the actual procedure itself, but it goes through some facts, and some of the slides are on there, most of them are not. No matter what treatment that you choose, there is a potential for side effects and complications. And some of these can be life-changing. The top two, incontinence and erectile dysfunction, are the most sort of widely talked about and most concerning among men. But there can be other things as well. There can be injury to the bladder or bowel, or injury to the rectum. There can be inflammation of the rectum and bowel or bladder. Usually after radiation therapy that can happen. There can be secondary cancers, again, usually after radiation therapy. Sorry if I keep getting away. And then stricture disease as well. So there can be other things besides the top two. Now going back to the age migration, again, finding younger and younger patients diagnosed with prostate cancer. The importance of that is that most of these patients are continent, do have good erections. So it's important to them, as opposed to the gentlemen that are 70 and 80, and maybe that's not really important to them as much. But these younger and younger patients, they want their quality of life to be maintained. They want less risk of side effects. So these days we're placing more and more importance, not just on curing the disease, but minimizing the side effects. So it's almost, nowadays, even just as important as the actual cure of the disease. The top two, erectile dysfunction and incontinence, are two of the more important ones like we talked about, again, because these are young guys, and they don't really typically have many problems. Other things that patients are concerned about, convalescence, how quickly they can return to work. Again, a lot of these younger people are still working, they're not retired, so it's important to them to get back to work. Cost effectiveness, especially in this day and age of healthcare, it's important that this is cost effective treatment. And everybody wants everything the most minimally invasive. It's a sexy term. Everybody wants to sort of not touch you but still treat you. And again, it all sort of boils down to searching for something better, that people aren't really satisfied with the status quo. So again, HIFU may be just what the doctors order, maybe you be able to offer these things. From here on out, we're going to talk about HIFU, sort of what it is, how does it work, talk a little bit about the history of HIFU. It's a little older than you think. Who qualifies for HIFU, how the procedure is done, and the follow-up for HIFU. Talk about the results and where can you get it done. Any questions up to this point before we get going into the HIFU portion? All right, HIFU stands for, again, for high intensity focused ultrasound. Basically what it is, it's a minimally invasive way that we aim ultrasound beams to a point. And at that point, it creates energy, and a lot of it. And it creates energy up to 195 degrees Fahrenheit or 90 degrees Celsius in approximately 2 to 3 seconds. So we use the analogy, it's sort of like using the magnifying glass to burn a leaf, and everybody did that as a kid. I think this is Opie trying to start a fire here. If you hold the leaf close to the magnifying glass, nothing's going to happen. If you put it far away, nothing's going to happen. But when you find that sweet spot where all those light rays converge, it creates the fire. Same exact thing with the ultrasound. It's actually a very simple theory. And at that point, which we call the focal point, that's where the tissue gets destroyed, and that's where all the heat is made. Again, it's this external high-energy ultrasound beam, and now it's used ultrasound waves, not radiation waves. So this is safe. This is what we use to check your bladder when you come into the office to see if you've emptied. This is what we use to look at babies at the OBGYN. And we can focus this point wherever we want. We can move it around and aim it where we want to aim it. Another fascinating point is that just outside this focal point, the heat dissipates very quickly. So everything just after it and just prior to it doesn't get much heat at all, which is the advantage of it. And it offers potentially less risk of treating that area and also potentially less risk of damaging that area, meaning less side effects. So if you're aiming for a particular point, you're going to hit that point. You're not going to affect the area just before and just after it, which is important when you're trying to spare the nerves.
But are you saying that focal point is at the intersection of two beams or?
Many, many beams. And there's a little animation that we'll get to later, but the probe itself basically emits a whole bunch of ultrasound beams. But the shape of the probe is circumferential. Therefore, these beams cross, and at that cross section, that's the focal point. So everything prior to that doesn't get treated, everything after that doesn't get treated.
Yeah, it's Greg Pearson in trying to just to get to the focal point. I was heard of Pearson, the tissue between the outer surface of the prostate.
Right, right. And that's the advantage of this, where radiation, you need to go through tissue to get there. You're still going to treat that tissue. Now, we're a lot better at it now than we used to be, but you're still treating that tissue. You're still treating behind the tissue, which is the rectum and the bowel, which is why you can potentially get secondary tumors and potentially get inflammation or proctitis, cystitis, that sort of stuff from radiation treatment. So again, what is HIFU? It is radiation-free. Again, we're using non-radiation beams. This is safe ultrasound waves. It's non-surgical. There is no surgery involved. It's an outpatient procedure, in and out, go home the same day. It's minimally invasive, minimal to no blood loss, and if it does in fact fail, you can always repeat it. And the other nice thing is, if it does fail, you can always do any other treatment. You can follow it by doing surgery. You can follow it if you need to by doing radiation. So you really don't burn any bridges, which is nice. Now, HIFU itself, the technology itself is not new. The use of it for prostate cancer is relatively new. It began back in the 1950s. It was actually developed in the US in Indianapolis. It's been used to treat other things prior to treating prostate cancer. It's been used to treat enlargement of the prostate, or BPH. It's actually FDA approved to treat fibroids in the uterus. In 2004, the first international HIFU center opened up outside the US. And today, over 100 centers exist outside the US. Over 9,000 patients have been treated. That's both for cancer and without cancer. And over 1,000 patients have been treated for cancer, just sort of in the Western Hemisphere. That excludes Europe and Asia, where they actually got a head start on us in treating this, and are actually a little further ahead than we are. Over 400 trained physicians worldwide in this modality. Now, how do you know if you qualify for this? Basically, if you have localized prostate cancer, it's localized to the prostate. If your PSA is under 10, if your Gleason score, which is from the prostate biopsy, you get your Gleason score, if that's either less than or equal to 7, and importantly, if your prostate volume is under 40, less than or equal to 40. Now, we can potentially shrink your prostate a little bit if it's a little larger, but if it's significantly larger, the technology isn't there quite yet to treat larger prostates quite yet. But hopefully in the future, we'll be able to do that. The other important fact is you really can't have any of many calcifications in your pelvis. There's no way to know that until the time of exam, when the urologist performs the ultrasound exam at the time of the prostate. They'll be able to look to see if there's any calcifications there.
Calcification where?
In the prostate.
The prostate, how about seminal vesicles?
Seminal vesicles, it shouldn't matter the seminal vesicles, okay, unless you're treating the seminal vesicles. But typically, we don't treat that. Typically, we just treat the prostate.